आणि चेअरमन अँड इंटरनॅशनल कार्डिओलॉजिस्ट म्हणून सर फाउंडर चेअरमन म्हणून नोबेल हॉस्पिटलमध्ये कार्यरत आहे. त्याचसोबत त्यांच्या मॅडम डॉक्टर फिरदौस सय्यद मॅडम DNP कार्डिओलॉजिस्ट आहेत, DNP ऑफ गायनेकोलॉजिस्ट आहेत, त्याही तिथे नोबेल हॉस्पिटलला सेवा देत आहेत. तर आपल्या मोअर डॉक्टर्स असोसिएशन तर्फे मी सर्वप्रथम सर्वांचं स्वागत करतोय.
सॉरी हातामध्ये असं जरा ठेवावं लागेल.
एक प्रसाद मला दाखवा जरा पुढे
आवाज जाते ना
ते
आवाज जाते ना ते
जाऊ दे हां
त्या सवय लावत काय कुठे
काय आलं दुसरेच काय आहेत
तसे तसे भरपूर काय वळवतात मीटिंग
टेबल लावून ठेवा की तिथे असं
स्टँड
जरा पाच द्या कोरड पडली तोंडात.
आजच्या कार्यक्रमाचे साठी उपस्थित असणारे रुटीन चेअरमन रमेश गझेली आणि शेखर कसाब यांनाही मी निमंत्रित करतो. डॉक्टर शेंडे सरांनी त्यांचं स्वागत करावं. पुष्पगुच्छ देऊ. रमेश गझेली आणि शेखर कसाब त्यांनी थँक्यू. यानंतर आजचा टॉपिक जो आहे एमर्जन्सी इन कार्डिओलॉजी या विषयावरती डॉक्टर अमजद सय्यद सर आपल्याशी त्या विषयावरती माहिती देणार आहे.
Seniors and colleagues, good evening. After a long time, we are the summer of the 18 for especially moments of arches in the parking some sugar some situation but this is a way after seeing the surrounding of emergency in cardiology redundancy they have. It's a really good topic. Emergencies in cardiology are prospects for the pulmonary. Basically, emergencies in cardiology, the perspectives of from the primary point of contact. If you see the emergencies in cardiology, it is very important to recognize what is the emergency, and then basically life-threatening conditions because most of the emergencies cardiologists are using very less time to treat, and prompt recognition and clear diagnosis, suspicion and plan of action should be immediately taken. So this is the list of emergencies in cardiology like acute coronary syndrome, cardiac arrest, aortic dissection, pulmonary embolism and cardiac death, hypertensive crisis, then arrhythmias, cardiac shock, acute heart failure, There is LVF card, myocarditis or pericarditis, and Brugada syndrome. These all conditions require prompt diagnosis and treatment plan. So what is important is like how it presents to you. Like most of the patient comes to you with fixed 10 to 20 symptoms. And in cardiology, the symptoms are very common, are only 4 to 5, like chest pain, breathlessness, giddiness, loss of consciousness, perspiration. That's it. These are the only symptoms which patient comes to you. So you need to immediately suspect something and plan some diagnosis with minimal present investigation with you or clinical action, whatever we have. So acute coronary syndrome is the most common cardiac issue. Like 80 or 90% of the cardiac emergencies are because of acute coronary syndrome. This is the spectrum of disease in which there is a blockage in the coronary artery. So it includes 3 conditions: non-ST elevation myocardial infarction, ST elevation myocardial infarction, and unstable angina. This all happens because of blockage in the coronary. Most common pathophysiology is complete artery occlusion leads to ST elevation in the ECG, and that is the most dangerous condition. The second is non-ST elevation MI, in which ECG shows just subtle ST depressions, re-emergence, and there is a classic angina and other symptoms, and property will come positive. One more thing, most important thing I try to emphasize is the time of doing troponin. Most of us, what we do is immediately patient comes to you, you do ECG, if there are changes or no changes, you do property. That is not the ideal way to do property. At least you take 8 hours after the primary event. If there is a chest pain or dyspnea, sudden onset, if you are suspecting coronary syndrome, please order the troponin levels after 6 to 8 hours after the first event. Because sometimes there are very mild changes in the ECG, patient comes with a very classic chest pain or non-classic but cardiac chest pain. Mind you, just listen my words clearly. The patient comes with either a classic anginal pain or atypical anginal pain, cardiac pain, or non-anginal pain, and ECG is normal. So these 3 things what I told you symptoms are very subjective. It takes a long time to understand the classic or non-classic pain, even for a physician. Because you repeatedly see these patients, you realize which is classic and which is not classic. There are some features, but then still. So what is important is the triage. Triage means if you have some suspicion that this is maybe coronary syndrome, why you should have suspicion? Looking at the background of the patient, elderly patient, diabetic, male, previous history of heart disease, you should always be suspicious. So you need triage. Triage means observe the patient for longer time, repeat single ECGs, and do troponin at the proper time. That is what you can do at your level. Then other tests are like, of course, echocardiography and angiography is probably not possible everywhere. So this is very important. Many patients we reject saying there is nothing. Troponin normal, ECG normal. You send the ECG to some cardiologist or physician. He said looks normal. You do troponin is normal. You send him home. Next day you realize the patient has a cardiac arrest at home, got admitted to some other hospital, got an angioplasty. Because initial presentation may not be very classic. So clinical acumen development to suspect something is very important. This is the acute coronary syndrome. In which you this stratify which acute coronary syndrome require immediate attention or invasive therapy. That is ST elevation MI with complications like heart failure, severe non-stop angina, ongoing angina, severe ECG changes, either depression or ST elevation, bilateral clefts, desaturation, hypotension. These are the present with chest pain and ECG changes or acute coronary syndrome. These are the patients who require immediate invasive therapy in the form of angiography or angioplasty. They may require the ventilatory support. They may require the circulatory support in the form of inotrops. So ICU care. So differentiating these things from taking out patients of these high risk subset of patients from a spectrum of acute coronary syndrome is very important. So this is all about acute coronary syndrome. So you need to have plan. Most important is initial stabilization that definitely can be done at your level, giving loading dose of clopidogrel, aspirin, and atorvastatin, giving sorbitrate, giving some fluid if there is a hypotension, some fluid. I'm not telling very 2-3 points of fluid. shock that your fluid may create problems. So garden fluid, initial fluid challenge of some 200 or 300 ml fluid with some putting some dopamine infusion and giving loading dose. It's referring to other place or wherever it is possible nearby ICU to further develop. That is called initial stabilization. Second is reperfusion therapy. What is reperfusion? There is occlusion of the artery, so the perfusion is lost. You need to open that artery. The most available and most easy and cheap way is to thrombolyze the patient with streptokinase or antiphase or other forms of thrombolytic therapy. That is reperfusion. Third is antithrombotic. After followed by that, you need to give antithrombotic in the form of vasopressin. Then revascularization. That is, you make sure the artery is open. That is only can be done invasively by doing an angiogram. So what it can be done is giving a thrombolytic therapy. Nowadays, people are giving thrombolytic therapy in ambulances with only support of technician on site and online some cardiologist or a physician. So might as well, most of you are running ICUs in forward now. So I don't think there is a big issue to go for a thrombolysis nowadays. You can be in touch with some center which caters all those kind of cardiology services and you start thrombolysis. It is legal as well. Even if nobody is a physician or a cardiologist present, a technician on-site present and online cardiologist can plan the thrombolysis therapy and shift the patient. So that should be done. That saves a lot of lives.
चालू करा
So time is the myocardium because the early you thrombolize, early you revascularize, the survival of myocardium is better, long-term complications are less, and arrhythmias, heart failure, everything is less. The other emergency in cardiology is cardiac arrest. First we should see what is the causes of cardiac arrest. I mean, 80% of the cardiac arrest is secondary to heart. What is cardiac arrest? Is sudden heart stops pumping and there is a hypertension of pulseless activity and even respiration becomes very laborious and there is a loss of consciousness. In layman's, sudden collapse. So this sudden collapse is generally cardiac arrest. 99.9% is a cardiac arrest. So what you need to do is you all do CPR, immediate CPR. Nowadays, public volunteers are trained for CPR like basic life support management and all everywhere. And even government is installing defibrillators in bus stations, railway stations, airport. So what we do, we have to do such patients immediately start CPR. The recent guidelines is at least 100 to 120 times compressions, which must be 5 to 6 centimeter deep at the mid of the chest, not left or right. And that is more important. Then early defibrillation is very important because only just these patients have ventricular fibrillation or asystole, so or ventricular tachycardia, which they collapse. So reversing this rhythm is possible only with shock. So, but then of course shock is not available most of the time. But whenever this happens at the hospital at least, or near the place where there is AEDs kept, automatic defibrillators are installed right away in some public places. So immediate defibrillation is very important. But if the defibrillator is got in, by that time you should continuously compress the patient. And by doing this immediate compressions, immediate CPR following by defibrillation, 10% of the patients can be survived. And 10% is a very big number. Out of 10, one patient is surviving is also worth doing it. So the basic training in CPR should be taken by all general practitioners, even volunteers, our staff, and everybody. So in our Noble Hospital, we tend to do these training sessions for all the staff, even our mama sheep, our sweepers, everybody knows how to do CPR. We are training them regular basis, even we are sending them for certified courses also. So that should be there everywhere. Next. So post-resuscitation care, such patients require continuous monitoring, oxygen therapy, ventilator, then targeted therapies like if it is MI or pulmonary embolism, you need interventions. Then you need sometimes ECMO. ECMO is something which is heart and bypass kind of a thing. You bypass the heart and do the oxygenation from the machine, which is very costly and not available in Solapur at least. Then the targeted therapy. What is the cause of cardiac arrest? If it is MI, do angioplasty, or if it is because of arrhythmias, put a defibrillator in the heart. That is called intracardiac defibrillator. So these are the way of managing cardiac arrest in emergencies. Next, aortic dissection. You know the aorta is the largest vessel which starts from the heart and supplies the whole body. Ultimately, the branches of aorta supplies the brain, liver, kidney, lower limb, upper limb, everywhere. So the ascending arch of the aorta or descending aorta, this is a very thick walled structure. They have media, intermedia, and adventitia, three layers. So in intima and media layer, there is a dissection and the formation of false lumen. This happens in condition when there is a hypercholesterolemia, already cholesterol deposits are there, sudden hypertension, sudden smoking or stress or alcoholic stress, or sudden severe hypertension. This leads to plaque rupture and there is a false lumen formation. And this dissection lumen starts from the ascending aorta, can go up to the descending aorta. Huge false lumen formation. And this can rupture in pericardium leading to pericardial fusion, or pleura leading to pleural effusion, or rupture in the abdomen, sudden loss of huge blood and cardiac arrest. The patient dies. But if the patient have contained rupture, some loss of blood in somewhere, but the rupture sealed, they come to you. If you diagnose, what is the symptom? Severe chest or back pain. Most common is back pain. The diagnostic parameters are severe back pain, or sometimes not associated with sweating, and pulse are unequal because of dissection lumen. Right side pulse is less, or left side pulse is less. BP is very high. So such patient requires again imaging, echocardiography, transthoracic or transesophageal, or a CT scan, and diagnosis of types of aortic dissection, A or B. A dissection requires major surgery. There is ascending aorta and arch of aorta. Because it involves sometimes the major arteries of upper limb, neck and brain, so they require immediate surgery. Surgery is very costly. Solapur probably, I don't remember anybody has done aortic dissection surgery till now. In my 16 years of practice, I have not seen any surgeon doing aortic dissection surgery in Solapur. But most of the places nearby, Pune, Hyderabad, they do surgery. It is a costly, very high-risk procedure. But it is done and patient survives. But time, the patient gives you time, you can send it and patients. I have sent many patients from Solapur to Pune or Hyderabad and they got operated. Type B dissection gives you a lot of time. Dissection is only descending aorta. So these organs, if they are even hypoperfused because of dissection, like kidney and liver, they don't immediately die. So they give more time. Few dissection of B type doesn't require surgery, only medical treatment. There is no medical treatment definitely, but you prevent it further complication by keeping blood pressure under control, heart rate under control, that's all, and decrease the pain. Next. This we have discussed next. So I told you the surgical treatment of type A and type B, medically managed, or nowadays endovascular treatment. So dissection, wherever the dissection starts, put a stent inside, so that the dissection point, if you put a stent, there is a communication is lost between the true and false lumen, and the false lumen collapse, and only true lumen remain. So putting a stent is an option. Again, very costly. This stent, only stent will cost 5 lakh to 10 lakh rupees. Only stent. Put together the whole procedure maybe 20 lakhs. Solapur is also probably is not done. Maybe one case actually was just not bad. Even we planned one case. I had a patient of aortic aneurysm leaking. So the stent cost was 5 lakhs. Somehow we convinced the company, since it was a first procedure in Solapur, he was willing to give 3.5. We told patient 4.5. Just 1 lakh for all other things in the hospital, like surgeon was involved, cardiologist was involved, everything. Patient was giving 2 lakh rupees. Patient paid advance. The person started from Pune, I remember, this 1 year back. And he was halfway, patient had sudden cardiac arrest. We gave a lot of blood, there was pericardial disease, drained with BP was 60. The lady died before that fellow came from Pune with stent. So it's an emergency. Next. Pulmonary embolism, you all know. See, very high mortality, very good presentation. I tell you, all these patients, they present with only vague symptoms, not very classic. For example, aortic dissection. They just come for vague pain. Only sometimes they come only with very high blood pressure. Like this pulmonary embolism also, they come with hypoxia, like your COVID. They come with saturation of 80, but there is nothing. BP is normal, breathlessness nothing is there. But once you see, you do the echo, you do the ECG, you do B dimer, then you come to know there is a problem. Or sometimes they suddenly come with collapse because severe massive pulmonary embolism which happens suddenly. Suddenly RV fail, there is hypotension, shock and collapse. So variable presentation, you don't know. The intervention is very important. The diagnosis is very important. Next. So what are the risk factors? Recent surgery or trauma, prolonged immobilization, active malignancy, hypercoagulative state like genetic disposition, pregnancy and postpartum period, history of previous thromboembolism. So these are the patients who are prone to develop clots in the legs. In leg veins, these clots goes to heart and blocks the pulmonary artery. There are three types: mild pulmonary embolism, moderate pulmonary embolism, severe pulmonary. Mild, only some desaturation, some dyspnea, because very small thrombi goes in the pulmonary artery. Moderate, there is more dyspnea, more desaturation, or half occluded arteries, either right or right pulmonary arteries. Massive is sudden total occlusion of main pulmonary artery. And these patients generally don't survive if they don't come in time. So what is the treatment next? How to diagnose it? Nowadays the new concept is PERT. PERT is pulmonary embolism response team. In US and other countries, the teams are formed. Once somebody suspects a pulmonary embolism, it is referred to a PERT team. PERT team is pulmonary embolism response team, which include the intensivist, a physician, a cardiologist, an intervention cardiologist, a cardiac surgeon, and an anesthetist. So they decide, depending on the reports of ECG, B dimer, CT pulmonary angio, clinical condition of the patient, and all the background. So they decide how to go about it. Whether the patient is a candidate for thrombolysis, or patient is a candidate for putting IV secretor, patient is a candidate for removing thrombus with the aspiration catheter. Nowadays they are doing it. So that the team will decide and they act fast. So by doing this team approach, a huge number of patients is being survived now, and mortality is decreasing in US and other countries. We are not that much not clear, but much organized, because patient walks with a pulmonary embolism to me and say, if it is coverable in the Mahatma Jyoti, otherwise I will go home. So we are not serious about it. We are very serious. Next. Cardiac temporal. Cardiac temporal is a condition in which, everybody knows that heart has a membrane around the heart, that is called pericardium. And there is a cavity between heart and pericardium, that is called pericardial cavity, which is thin layer fluid is there, like 50 ml fluid maximum, which is required for lubrication. When heart moves during contraction, you require some lubricant, that is pericardial fluid. So that is normally present. When this fluid suddenly increases, what happens is, the space is small, but because of the large volume of the fluid, the pressure in the pericardium increases and it compresses the heart, it throttles the heart. So what happens, the performance of heart goes down, the cardiac output decreases, BP decreases. This is a condition which is called cardiac tamponade because of pericardial. So how this happens? This happens either slowly, which patient accommodates slowly, so they walk with this condition comes to you. Only symptom is some breathlessness, some cough, some dyspnea, and then you realize the ECG is very low voltage, BP is slightly on lower side, saturation is slightly on lower side. You do the X-ray, the heart is very large. You do the echo, there is huge amount of fluid in the pericardium, and there are some echo signs of cardiac temporal. See, only echo may say minimal pericardial effusion, moderate pericardial effusion, severe pericardial effusion or large pericardial effusion, and with large pericardial effusion there is a cardiac temporal. These are the four types of echo report. Cardiac temporal happens lastly, means once fluid accumulates, it increases, it goes to a critical level, then it starts compressing the heart. That is the condition called cardiac temporal. That is the time you require mechanically remove the fluid, otherwise patient will not survive. If it is slowly happen, you have some time. You can plan it, you take the cath lab and do it, the procedure under fluoroscopy guidance, put a needle and catheter, take out the fluid. But if it happens suddenly, like a cardiac rupture or aortic dissection or any trauma, You need to do it on bedside. Just ultrasound, see the fluid, put a needle or something and aspirate. Otherwise, patient will not give time. You cannot take him till the cath lab. Next. So these are the acute presentation. What are the cardiac symptoms? The symptoms are like dyspnea, tachycardia, tachypnea, sometimes confusion because of the decreased cardiac output, decreased cerebral circulation. This is the true state. What is back triad? Back triad is like hypotension, elevated JVP and heart sounds are muffled because of the fluid. This is present pulsus paradoxus. What is the paradox? There is a hallmark sign, pulsus paradoxus, and an inspiratory drop in systolic pressure exceeding 10 to 12 millimeter. Generally, in inspiration, there is increase in pressure, but there is a drop in this condition because in inspiration, the fluid is more, the outcome to the heart is more. Because of pericardial fluid, again there is a compression and pressure drops. That is called pulsus paradox. Next. So I told you the diagnostic X-ray, ECG, and echo. By 3 ways you can diagnose. Or sometimes you may require a CT scan to see the effusion. Effusion is already seen. But suppose you want to see what is the cause of effusion. Maybe there is a lung malignancy causing effusion. There is some suspicion in the X-ray, you are not very sure. So patient gives time to do a CT scan as well, so that cause of pericardial effusion can be detected. Next. So it's a life-saving procedure. I told you, if the patient gives time to take him to the cath lab, under fluoroscopy guidance, put a line, put a needle, inject contrast and see whether the cavity is pericardial cavity, then put a wire, on the wire put a sheet, and on the sheet put a long catheter, and keep the catheter here outside and drain it, and see by through the echo whether the whole fluid comes out. And what we do is we put a pick there and take out the whole fluid, see the cath lab by echo and fluoroscopy, make sure there is no fluid, and we keep that pick there for 3 days. And daily we just do an echo say whether it recollects. If it doesn't recollect, we take out the pick there 3rd day, and the patient is cured. But then you treat the cause. This is only mechanically taking out the pericardial fluid. But what are the causes? Most common is tuberculous pericardial effusion. You have to start the ATP. Sometimes pyogenic, you have to give very high antibiotic for 5 to 6 days. It resolves. Sometimes malignant, you treat the malignancy, then it resolves. So treatment of the cause is more important. But then emergency is to take out the fluid, then find out the cause and treat the cause. Next. Hypertensive crisis, you all know there is urgency or emergency. What is the difference? Urgency is you have some time to reduce the blood pressure. This is the common patient comes to your OPDs. Some mild giddiness, mild headache, and pressures are very high. So there is no end organ damage, only symptoms. But some patient comes to you, BP 220, 120, loss of consciousness. Some patient comes to you, BP 220, 120, chest pain. So these are the emergencies. Chest pain, loss of consciousness, IC bleed, MI with hypertension, or breathlessness with 220, 120. So these are the emergencies that requires immediate control of blood pressure. Urgency doesn't require. These patients are coming to OPD, you refer to us, we do echo and we find out renal Doppler, all those things. And we treat slowly, I think 24 to 40 hours, we reduce the pressure, that is all right. But when there is emergency, you have to be very fast. Next. That's what I told you. Emergencies can lead to hypertension, heart failure, intracranial case, aortic dissection, acute renal failure, other symptoms, and underlying causes you all know. Next. Next. Arrhythmias. Either tachyarrhythmias or bradyarrhythmias. What is tachyarrhythmias? Is fast heart rates. What is bradyarrhythmias? Slow heart rates. Tachyarrhythmias is most dangerous. I told you ventricular fibrillation or ventricular tachycardia. These patients have pulseless. The BP is not recordable or hypotensive. If they come to you walking and BP is slightly low, and the ECG shows some stable ventricular tachycardia, you may plan cardamom infusion or digoxin infusion or xylocard infusion. But if the patient comes with severe breathlessness, hypotension, and the rhythm is very irregular, these patients require defibrillation. That is very important. So to differentiate between whether the patient requires OPD treatment in the form of tablets, or a patient requires IV drugs, or patient requires shock, or what can happen with this rhythm. So to differentiate these four types of arrhythmias, it is very important. Either it is a ventricular tachycardia, ventricular fibrillation, supraventricular tachycardia, or ventricular fibrillation. Out of this, ventricular fibrillation patient will not be seen in few minutes. Because if you don't act, you will die. So if somebody is in shock collapse, please it is BF. If you have defibrillator, just put it and do it without seeing the rhythm. So that's what we do. If the patient comes in the casualty with the collapse state, we have a defibrillator. We don't record ECG. We don't see anything. We just put the pad and shock. The patient is totally collapsed in pulseless. 99% of the time it is BF only or asystole. Just do that. If the patient comes to you with severe tachycardia perspiration but BP is 100 and ECG shows white fluorescent index, it is probably ventricular tachycardia. So in such patient, sometimes is there to give IV carbon, bolus or Xylocar, see for some time, otherwise shock. If the patient comes with 200 heart rate but very stable, that is a supraventricular tachycardia arising from ATR. This gives lot of time, but still, we try IV bolus, cardamom, Denzium, adenosine or a carotid massage. Lot of patients we are doing on an OPD basis. Do carotid massage, they break. The patient is over. Long term therapy in the form of medical treatment, 80% patient doesn't require anything. But recurrent supraventricular tachycardia, we require invasive therapy in the form of radiofrequency ablations. Atrial fibrillation again. This is more dangerous because atrial fibrillation can lead to formation of clots in the area, leads to strokes. So, converting the atrial fibrillation to a normal sinus rhythm should be the always goal. But unfortunately, 80% of the patient of atrial fibrillation will have some underlying heart disease like mitral stenosis, aortic stenosis, heart failure, lung dysfunction. So, converting to normal sinus rhythm is generally impossible. So, to control the rate is very important. Give lenoxin, diltium, cardamom, beta blockers, control the rate and give some anticoagulation to prevent stroke. That is the treatment of atrial fibrillation most of the time. Next. So this we discussed already. Next. Bradyarrhythmias, just in short I will tell you, either a sick sinus syndrome in which the patient is in sinus rate but very low heart rate, symptoms of sudden loss of consciousness repeatedly. If this is diagnosed, probably they require a pacemaker to support the heart rate. Another is AV block first, second degree or third degree. Generally third degree complete heart block will have only heart rate of 40 and AV dissociation. These patients again require a pacemaker. So 99% of the bradyarrhythmias require pacemaker. But then again, cause of bradyarrhythmia is important. Suppose a patient is having acute mitral MI and complete heart block. So does he require pacemaker? Yes, but temporary pacemaker. Once you open the coronary artery, once you normalize, the heart rate will reach. Some patient with some drug toxicity, like beta blocker, will come with 40 heart rate. Does he require pacemaker? No. You can use support of temporary pacemaker for a few days, stop the drug, and make sure that the rhythm comes back. Or suppose a patient is having renal failure because there is a hyperkalemia, potassium is 7, and because of that there is a bradycardia. It comes to me, heart rate is 30, BP is low, I put a temporary pacemaker, I correct the potassium in 2 days. Then heart rate becomes normal, permanent pacemaker is not required. So every patient of decrease in heart rate or CLP doesn't require pacemaker, but most of the patients require permanent pacemaker implantation. Next one. Cardiogenic shock, cardiogenic shock means shock arises from heart. Most common again is heart attack. So we have discussed the treatment of heart attack. Next. So what we discussed is hypertension, emergency, arrhythmias, cardiogenic shock. See, these all require initial diagnosis. And what can be done at the primary level is ECG, clinical examination, BP, SpO2, X-ray, and clinical discussion with some seniors or colleagues or specialists. If you do this, probably 80% of the diagnosis is at the primary level. Because what next remains is only echo and angioplasty with us. So if we discuss together, probably we diagnose, we come to the nearer to the diagnosis. If we discuss together, we do some basic ECG, SpO2 and X-ray. Heart failure, again we discuss I think acute heart failure, most common is again MI and other causes. Next. Myocarditis Even though it is a rare condition, you must have seen some patients, young patients coming to you with severe breathlessness. Heart rate is 140, 150, ECG, non-specific changes. You sent to me, I said there is LV dysfunction, doctor is positive, but it is not heart attack. This happens in myocarditis. Post infections, routine viral infection, even common cold virus sometimes affect the heart and it causes irregular rhythms, arrhythmias, heart failure, LV dysfunction. That is myocarditis. Unfortunately, there is no definite treatment. Only supported treatment is there. Slowly they recover. 80% of the myocarditis will recover, but 20% of the patient remain lifetime LV dysfunction and they succumb after some time. Next. Cardiac MRI is very specific to diagnose myocarditis because it shows all the changes. Next. Gurgada syndrome. This is the last one. Only 2 minutes will take. This is one condition. Last slide. Next. This is the classic ECG of Gurgada syndrome. Patients have some peak versions and stroke moving coded T waves in DB1, B2, B3. These patients present with sudden loss of consciousness. They have arrhythmias. This is a genetic defect. If the ECG is very classic, this straight away, if they have symptomatic, they already suffer 2-3 syncope or cardiac arrest, these patients require defibrillatory collaboration in the heart. So this is not very common, but it is one of the cardiac emergencies. The moment you see the ECG and you see the background of patient recurrent syncope, probably it's a cardiac emergency. Keep it with the observation, plan everything. Thank you. Next. Thank you. Actually, these all topics are very big topics. We tried to cover within a very short span of time. I was very fast, so sorry for that. But any 5 minutes or 2 minutes we keep for some discussion of any queries, because these are emergencies, sometimes very interesting cases. People also know. Ultimately, we think something turns out to be something. This happens in your emergencies also. Any queries? No queries. No.
So thank you very much, sir, for enlightening us emergencies in cardiology like ACS, acute coronary syndrome, cardiac arrest, aortic dissection, pulmonary embolism, mild, moderate, and severe pulmonary embolism, cardiac tamponade, and emergency OPDs like hypertension, arrhythmias. Thank you for nice idea for cardiology. Thank you, sir. I request to have the dinner.
काय काय
40 मिनिटं झाली.